Do you want CE credit for listening to Medic Mindset? I'm excited to announce that it's now possible. Prodigy EMS has this episode and a bank of Medic Mindset episodes where you're able to easily convert your listen into CAPCA-approved CE. I've been waiting patiently to find the group of educators who align with the mission of Medic Mindset, and I've finally found our people. A link for the CE is in the show notes at medicmindset.com. Do you want to spend some time on ultrasound?
No.
Liar. Well, let me ask you some specific questions.
Well, let me get. I want to talk.
No.
No.
You go.
Look, whose podcast is this? Is this your podcast or my podcast? Oh, it's your podcast. That's right.
Welcome to Medic Mindset. I'm Ginger Locke with another episode of the Thinking series. I'm happy to report that the white tiger is back. Dr. J.R. Pickett discusses how he thinks about abdominal pain. You want to talk about abdominal pain?
I do want to talk about abdominal pain.
So this is the 10th episode in the Thinking series. And You've done 2 already. One was syncope, another was shortness of breath. Those have been listened to a lot. So I'm looking forward to people getting a lot out of this one. The very first one was thinking chest pain. And it was with a physician named Brandon Blease. He spent a lot of time talking about abdominal pain because of the radiation into the chest. So I wondered if we might get into some chest stuff with abdominal pain. Where I usually like to start with this is what are the bigs? What's the big dangerous stuff?
I'll tell you, I had a patient in the emergency department. She comes in with epigastric abdominal pain, and she is just writhing in pain. I mean, she's about maybe 60 years old, and she's so uncomfortable. You can see, you can see the pain in her eyes. You press on her belly, and it's not that tender, but it's right up in here. So spin a quick 12 lead EKG. It's normal. Her vital signs are okay. She's a bit tachycardic because she's obviously in so much pain. I'm like, wow, okay, maybe she perforated an ulcer, because that looks that way. When you perforate an ulcer, it's like, boom, sudden onset. Oof, really, really painful. So I sent her to CT scan and just had them do a quick non-con CT, and she's in the scanner. They're like, hey, does she have a known thoracic dissection? And I was like, excuse me? Like, I'll be right there. And so I go over to CT scan, and sure enough, she's got this ascending, descending aorta dissection, and it's a nightmare, a vascular nightmare. So from the CT scanner, I'm calling blood bank, ordering a whole bunch of units of blood, calling surgery, and we get her back to the room in the ER, and I talked to her. I said, okay, this is what we found, and we need to get some blood for you. We need to get you to surgery right away, and we're giving you some more pain medicines. We'd already given her some fentanyl to control her pain, but and we're going to do these things, and we're going to see what we can do to get you better. And as I'm telling her this, as she's looking at me, the lights go out, and she dies right in front of me, and there's nothing to do to help her. And it started with epigastric pain. That was the concern. So you have certain priority diagnoses with abdominal pain. Now, it's such a black box, and you get pain referred from elsewhere. But things that we talk about, one is the vascular catastrophe, so the thoracic aortic dissection, the abdominal aneurysm, then acute myocardial infarction or myocardial ischemia can certainly refer pain to the belly and to the back. Ectopic pregnancies. A woman of childbearing age, in God we trust, all others get a pregnancy test. And this, of course, is a huge thing. Any kind of a perforation of a viscus is death if it is not treated. So a perforated ulcer, perforated diverticulum, esophageal rupture, these are all big things with very big mortality rate if untreated. Even esophageal rupture has a high mortality rate even if treated. Obstruction is a big thing. So bowel obstruction, small bowel or large bowel obstruction. And pancreatitis is another one. So hemorrhagic pancreatitis can be deadly. And lastly, ischemia. So mesenteric ischemia, bowel ischemia. So you can have a heart attack. Well, the same thing can happen to your gut. You can throw a clot and impede the blood flow to the gut.
I didn't really know that till I started teaching. I don't remember learning about mesenteric ischemia, but I did once I started teaching.
Well, it's terribly painful, and the one of the key hallmarks of that diagnosis is it's pain out of proportion to exam. So they're having a lot of pain, and you press on them, and they're not all that tender. And You're like, wow, what's going on here? Not that tender. And sometimes it can be intermittent. So you can have narrowing. So just like we have angina of the heart, you can have angina of the gut. And then we do scans and all this stuff and everything looks pretty normal. And it can be very challenging to diagnose. As I learned more about vascular issues with the gut, you have such a thing as vascular migraines of the gut. So you have abdominal migraines. So, kind of similar sort of vascular phenomenon that occurs in the head can happen in the abdomen and can be a cause of recurrent abdominal pain.
So I started you talking about mesenteric ischemia. Was that your list though? Did we make it through it?
That's my list of the priority diagnosis in most abdominal pain. I mean, there's always like other stuff like a testicular torsion can cause abdominal pain, but those are like the really big ones. When you say I've got abdominal pain, those are the ones I'm concerned about because they can be immediately life-threatening. Yeah. I mean, appendicitis can be life-threatening if untreated, but those things that I just listed, those are things that can like kill you in front of you.
That was actually a note I made. I wanted to ask. So when something perforates, is it the bleeding we're worried about or the peritonitis, sepsis? Or yes, or both?
Yes. The peritonitis and sepsis, we've got a little bit of time, but surgically you need to go in to fix that and need to get the antibiotics on board. The perforated ulcer or diverticulum, one of the issues is that those places where they tend to perforate tend to be right around vascular structures, and that's where there's weakening in the wall. You can end up with this flood of blood. And the diverticulum can perforate right on a vessel, and then you get this frank, bright red bleeding by stool and a fair amount of it. With the ulcer that perforates right around that gastroduodenal artery or something like that, then just starts dumping blood into the gut. And in fact, can not only cause immediate pain and could cause vomiting of blood, but can also cause syncope. So it's not an uncommon diagnosis. When you've got that flood of blood into the stomach, then it just causes you to pass out.
I was thinking about it in terms of, so you've got bleeding, the vascular stuff, as you call it. Then you've got ischemia, and then I think a third is sepsis. I kind of chunk it into three things.
There are other life-threatening things in there, too. Diabetic ketoacidosis, for example. Folks that get DKA, then they get these ketones circulating, and then they get an ileus, so this slowdown of transit.
I've always wondered why they had abdominal pain.
Yeah, they get the ileus, and things stop moving. So ileus is like, there's obstruction, which is like it comes to a halt, where there's something blocking the movement. There's ileus, where the gut just kind of relaxes, and it doesn't move things along. You get that lack of peristalsis. Both are very painful. Both can cause vomiting. You have kind of a similar clinical picture. But this is why our DKAers tend to have that belly pain.
Okay. I think I want to know, how do you approach these, right? So we know it's abdominal pain. Do you do a little bit of risk stratification early on where you figure out their age? Absolutely.
So you have your high risk populations. Anybody of extremes of age. So for the elderly, acute abdominal pain, 14% mortality, somewhere around there. So it's actually a higher mortality rate than an acute MI for somebody who's old. So abdominal pain in the elderly is scary stuff.
And what specifically is happening for them?
They are much more likely to have these priority diagnoses, and also the vascular issues and the MIs, and also cancer is a big one. So 11% of patients who present to the emergency department, of elderly patients who present to the emergency department with abdominal pain, are diagnosed with cancer within a year. So it's a big thing. So even if they're not diagnosed at that emergency department visit, abdominal pain in the elderly is really scary. Likewise, for the very young, for babies, it's very scary because, one, they can't give you a good history, so they can't describe what's going on very well, and we tend to be very cautious about radiographic imaging in kids because we're like, oh, they're really young. I don't want to do ionizing radiation. And then we end up having diagnoses that get that delayed. So a large number of patients who are, these young kids with appendicitis, they end up perforating before we diagnose it because we're hesitant to do the CAT scans. And fortunately, ultrasound is helping to change that for us. Pregnant patients, likewise, a lot of these issues like cholecystitis and appendicitis, they end up having delays in diagnosis because we're hesitant to image them. And also when we do things like ultrasound, because you have this gravid uterus, it kind of moves things around, and that can be tricky. So the extremes of age, the pregnant, Those with abnormal vital signs, like if you're showing any signs of hypotension, then that's a big deal. That gets my hackles up there. Folks who are pale, who are diaphoretic when they've got belly pain, which that can be a response to a visceral stretch. Certainly, I mean, if you've been hanging on to that bowel movement for a little bit too long and you decide it's time to go and you're like, oof, you have that sweat, the pale. So the visceral stretch can do it, even though that's obviously, generally not life-threatening when that occurs. But you're like, I'm going from prevention to triage. I'm crowning here and running to the closest restroom. Right. But
thanks for the visual.
Yeah, well, it's some people are just listening to this podcast. I need them to have some sort of visual as to what's going on. People with severe pain, with rapid onset of pain, that's also big in my mind. So, that's it. Extremes of age, abnormal vital signs, looking pale, diaphoretic, looking chalky, severe pain with a rapid onset. Already, I'm thinking this is potentially something life-threatening and moving that direction.
So the severe pain is a tough one, right? Because it is subjective, it's qualitative, it is personality dependent, it's culturally dependent. I have used pain to help me decide if somebody's sick or not sick. Is that right? I mean, I felt a little bit like maybe it was just kind of novice stuff. Like I've never seen someone respond to pain like that.
Certainly with our patients who have chronic pain, they don't generally react the same way that somebody without chronic pain does. So they get used to the pain, and so they react in different ways. They may not give us the appearance when they say, I've got 9 out of 10 pain. They may not look like somebody to us that has 9 out of 10 pain. Like, if I shatter my tibia or something, that's going to be like 9, 10, 11 out of 10 pain. And they may not look that way. So I take them at their word for it. Yeah. When they say, my pain is at this level. And that's if you can put it in the concept in terms that they can understand. So when you say, on a scale from 1 to 10, what's your pain right now? Like, okay, that's a useless question. But if you say, if we go from 1 to 10, where 10 is the worst possible pain you could imagine, like having a baby or a kidney stone or shattering your leg or something like that, where would you put this pain right now? And I mean, you'll still have some folks like, oh, it's the worst. It's literally a 10. It's awful. Like, hold on, I need to Instagram this. Okay, I don't really believe you. But the emotional reaction has a lot to do with it too, because pain comes with an emotional reaction. But also abdominal pain is frequently associated with psychiatric disorders. So that's another piece of it. And chronic abdominal pain or recurrent abdominal pain can be an indicator of some underlying psychiatric disease also. And that confounds our picture of it.
Right.
But if somebody says, my pain's not so bad right now, that doesn't mean they necessarily don't have a priority diagnosis. As you said, there's so many different factors that go into that.
Yeah, it's just a full gamut, all the way from very still, very stoic. You see a little bit of sweat beading up on their brow, their upper lip, but they're super still, all the way to the, screaming. So
I'll share a little story with you. About 3 years ago, almost 4 years ago, I had appendicitis. I had acute appendicitis. And my family was out of town. They're visiting my in-laws, and so I was here alone. I'd just finished doing a couple of dives out of Lake Travis, and I come home. I just feel kind of gassy. I'm like, I just feel uncomfortable, and it didn't really go away. And I'm like, I just feel kind of meh, right? And I'm thinking, maybe I ate some bad food or something, and I know it. I'm gonna have diarrhea, and like, that's okay. Like, I got my iPad, I got Netflix. I can just kind of gut it out. Like, gonna be it'll be all right. And I didn't. And then I threw up, which I almost never do. And then I got a fever. And like, man, what's going on? Like, for 8 hours. This is what an astute emergency physician I am. Like, 8 hours I suffered with this before I finally examined myself. And I'm like, oh, okay, yeah, I know what this is. And I'm going to the hospital. So then I have to decide, how am I going to the hospital? Right? Like, am I going to buy ambulance? No, I'm not going to take an ambulance out of service. That seems kind of silly. Then which hospital do I go to? Do I go to the one where I work, where I know people, because I know I'm going to go to surgery and somebody's going to start my Foley catheter, and I don't know if I want the people I work with to do that. And and it's like 6 o'clock in the morning. I've been up all night. I've been miserable, and I take an Uber to the ER, and I I'm there by myself in the waiting room, like there's nobody else in there. Triage nurse sits me down, does the whole triage thing. My temperature is 100 point something. And she asks me the question, like, on a scale from 1 to 10, what is your pain right now? And I, like everything hit me all at once. The fact that I'm alone, I know I'm going to have surgery. I don't like that prospect. And I'm like, just like all of these things, all these emotions, just, and plus the pain was bad enough at that point. It was completely preoccupying all of my thoughts.
Right. I
looked at her, I just said, oh, it's an 8. And this like one manly tear rolls down my cheek, and she's like, okay, pumpkin, let's get you into a broom. Let's get you taken care of. And so that was, they took fantastic care of me, and from everywhere, from the ER up to the floor. But that was my experience. And now that question, I think of all the things that go into that question.
Right. What can you tell me about appendicitis? Because that's a big one on the list, right? So let's sit there for a second. The thing I'm most curious about is, what are the risk factors? Because I can't seem to figure out, like, maybe there aren't. Is it just some random?
It's mostly random, to be honest. It's the most common surgical emergency in this country. Although, cholecystitis is getting there too with this, increase in obesity that we're having. But about 10% of the population gets acute appendicitis. Mm-hmm. It's a great imitator. Like the atypical presentation is the typical presentation.
Right. I've had students with appendicitis, and they come back with all kinds of different presentation stories.
Yeah, it's like you want the periumbilical pain that gradually migrates to the right lower quadrant, associated with anorexia, maybe some nausea, low-grade fever, and all of that stuff. And that seems to be the exception rather than the rule. So it is kind of the great imitator. It can be difficult to diagnose at times. One thing, though, is in this country, we tend to operate immediately on appendicitis. So it's like, oh, happy, you go into the operating room, of course, super safe operation. Your chances of a good outcome are outstanding, and it's just kind of bread and butter. Like surgeons are fantastic at it. And anesthesia, which everybody's a little nervous about anesthesia, it's actually one of the safest medical specialties out there. Our colleagues across the pond don't generally do that. So if the patient's not perforated, if they're not septic, if they're not like grossly abnormal vital signs, then they do antibiotics and cool that down, and then operate on them at a later time. Mm-hmm. This is something that I teach for our special operations medics on the military side is you've got somebody with acute appendicitis and you're on a mountaintop somewhere and evacuation is difficult. Well, start the antibiotics, get that on board, and you might be able to buy them a whole lot of time with that. So appendicitis is scary because untreated, yes, it absolutely can be fatal. 100 years ago, it often was. Nowadays, of course, it's very rarely so, but it can be, but that's usually associated with a delay in diagnosis and not getting antibiotics, not managing that. Once you diagnose it, it's like, oh, okay,
so they plan to do an appendectomy. They just like to give antibiotics first to reduce the bacterial burden.
Well, the
beforehand,
the appendix is a problem, and that's but it is an infection.
Right.
First and foremost. So getting the antibiotics on board to cool that infection down, that inflammation. As that tissue gets inflamed, it swells, it gets kind of friable, it's a little more difficult to work with surgically. So giving them the antibiotics to help settle that down is a good thing. So the primary problem is not that little appendicle. The primary problem is we've got an infection in there surrounding it and will continue to grow. And as that tissue becomes more friable, then it can perforate. Now you're dumping gut contents full of bacteria right into the peritoneum, and that's when you get really, really sick and can die.
Yeah. Causing peritonitis. So can we talk a bit about peritonitis?
Yes. So it's important to talk a little bit about the different forms of pain that you have in the abdomen. So abdomen, great big black box, all these organs. So you basically have 3 types of pain that you'll find there. One is visceral pain, and this is the nerves that are surrounding those actual organs. It's not very precise. So when we're talking somatic pain, which is where you get inflammation of the parietal peritoneum, or so the body wall, those nerves are fairly sensitive and fairly specific. So it's kind of like if I take a needle and I poke you on your arm, that's more like somatic pain. Like you can tell me exactly where it was that I did that. But if I take that needle and I poke you on your small bowel, then you have a hard time localizing that. It just feels, kind of uncomfortable. But as the inflammation grows, so say an appendicitis or diverticulitis, as that inflammation increases, then it starts irritating that body wall, and that's when it localizes to that location. And then lastly, you've got referred pain. So if you irritate the diaphragm, such as with pneumonia, lower lobe pneumonia, you irritate that diaphragm, and then you can get some referred abdominal pain. I had a guy that came into the ER once, as a young dude, comes in with left lower quadrant abdominal pain. And so I press around on him, and he's like, a little bit tender, but nothing perineal. I do a genital exam, and the dude's got a testicular torsion. So that testicle had twisted on its blood supply, and it was in danger of dying off if we didn't fix that immediately. So that referred that pain up into the abdomen. It had nothing to do with his abdomen.
Right.
So those three types of pain, visceral pain may be just kind of vague and nonspecific, and that as that inflammation of that peritoneum goes, then it gets worse. Now, when you've got frank peritonitis, this is somebody that they don't like to move, and this is a usual differentiator between acute gut issue versus maybe a kidney stone. Like kidney stones, they can't stop moving. They're they're moving constantly, trying to find that comfortable position. The abdominal issue is they don't want to move it. As you move them, then it irritates that. You can use this to your advantage, though. As you shake or bump or anything like that, then you get a reaction. So this is where your percussion comes in when you're examining somebody. We get taught about rebound tenderness, right? You press real hard onto their belly, and then you let go really fast and see how quickly they can jump off of the table. But it's not terribly specific, and you can induce that in a healthy person. Percussion tenderness, however, is very specific for peritoneal irritation. So you just taps on somebody's belly. It's very non-threatening. It usually doesn't cause them a lot of pain. And so you can maintain some rapport with the patient when you do that, but it can irritate that. Other things is I'll ask him, how was the car ride over to the ER today? How was it? Oh man, every bump was just killing me. So that gives me a little hint. With little kids who have a more difficult time articulating that kind of stuff, I'll say, tell you what, I want you to hop off of the stretcher here. I don't mean jump, stand up on the stretcher and take a flying leap. But just, sitting, I want you to hop up here. And if they can't, if they don't do that, or they stand up slowly, and I'll be like, here, let me have you just jump. Just jump once. And the kid with peritonitis, from their appendicitis, they'll jump and then stand up slowly. So it's when they when their heels hit the ground, that irritates that. And so that can be a clue that helps. And again, you're not putting your hands on the kid and hurting them, so it doesn't necessarily damage that rapport that you've built with the kid.
Yeah.
Other things like doing that heel tap sign, so their legs are extended, you just kind of whack on the bottom of their heel with your fist, or I'll bump the stretcher and I'll come and do it and just kind of bump it with my knee and say, hey, did that irritate you? Did that hurt your belly at all when I did that?
So how will you pick which one of those to do? Just for standard adult, do you just kind of do them all just to give them all,
Yeah, I do them all. They're all super quick.
Yeah.
So it's getting a good exam is very important. And a lot of times we just sort of give kind of lip service to the exam. It's just all right, mash. Okay, we're done. So we don't really pay that attention to inspection first, auscultation, percussion, palpation. And I go in that order for a couple of reasons. One, when you palpate, you may move some gas around, so it may change the sounds that you hear. So I'll inspect first because it's totally non-threatening, and you can see if there's any. You can see if there's any caput medusa or Gray Turner sign or anything like
surgical
that.
scars, good conversation starters.
Yeah, because surgical scars, where'd you get this? Where'd you get this big scar here? I thought with a guy, where'd you get the scar here? Oh, I got shot. Oh, okay. And, moving on here, the chest tube scar. Where'd you get this from? Oh, yeah, I got shot. I'm like, you need to find better friends, my friend. You start with the inspection, then you do the auscultation. Listen for those gurgling sounds, and sometimes it may take a little while, but that gives you a clue. If you have a silent belly, then that means there could be some inflammation in there. You can get an ileus due to peritonitis, and things aren't moving along, so that's a good clue. Or you get a lot of high-pitched gurgling, and it leads you in the direction of an obstruction. So then you move on to your percussion. You tap gently on your fingers and put your finger on there and just just tap on that knuckle. And that takes some practice to get it well. You can hear if there's a ton of gas in there, you just dunk, dunk, dunk as you're tapping on them. You're looking for that irritation when you do it. My daughter loves this. She's like, "Daddy, can you check and see if I have gas?" And she wants me to percuss her whole belly. And it's just adorable.
Percussive therapy feels good. It's like little.
And then lastly, getting to palpation and feeling for masses, feeling for organomegaly. Although I don't typically expect a paramedic to be able to pick up like an enlarged liver or an enlarged spleen. Like if you can, great, that's fantastic. But at least getting some information there, and not like mashing really hard on, super, super fast. There are some special signs, the psoas sign, where you're basically extending the hip, and you can see YouTube videos on how to do this. We're extending that, and so the appendix may be retrocecal, so it may be behind it, so it's laying right up against that psoas.
Right.
And as you stretch the psoas muscle, it rubs right up against that mad appendix. The obturator sign, so the appendix is really down, laying up against that obturator muscle. You take the leg and kind of twist it a bit. You can stretch that and irritate the appendix that's way down there in the pelvis. The Murphy sign, which a lot of people think is just right upper quadrant tenderness, and it's not. It's, you press on that right upper quadrant, kind of gently press in, but gently but firmly, I guess, and then tell them, take a big deep breath. And when they take a breath, if they're taking a breath and they halt that breath because of pain where you're pressing, then that's a positive Murphy sign.
Gallbladder?
Gallbladder is what you're thinking with that one. Cva tenderness, so percussing the kidneys in the back. So a lot of people think the kidneys are lower than they are.
I was going to say, like, describe where are the kidneys? Because people think they're down low, right?
Right, and they're
Myself
not.
Included for a long time.
They're actually protected by the rib cage. So that bottom part of the rib cage, right behind that is, or right deep to that rib cage in the back, is where you'll find the kidneys. So
I thought they weren't protected by ribs. That's how people get the kidney shot in martial arts.
Well, I mean, the kidney shot still hurts, and I can tell you that definitely for patients who've had pyelonephritis or have had an obstructive stone. When I do Cva tenderness, you put your hand on their back and just kind of thump it with your wrist or with your fist, and you're percussing it and trying to get that irritation out of it. And we call that CVA, or costovertebral angle tenderness. Okay. So costo, rib, vertebra, spine, that angle between those two, the kidneys sit right there. So you tap on that on both sides. And I put my hand there so it doesn't look like I'm like actually punching the patient in the kidneys, because nobody likes that.
That's good. I'll add that in. I've always just been giving them little taps.
Yeah, put your hand there, and you still get the same thing, but it doesn't look like you're abusing the patient.
Okay.
Then lastly, Rovsing sign is another one. So when you press on the left lower quadrant, there's pain in the right lower quadrant. So we can see that in appendicitis as well. Oh. All of these tests, they take seconds to do. So getting that good exam, there's really no excuse not to do that. And then, of course, ultrasound. So we've got ultrasound on all of our ambulances now. In abdominal pain, like unless you're like really experienced ultrasonographer, you're not going to pick up appendicitis with that. But
because of all those different places it can hide that you were describing?
Well, and there's specific findings to it, and it very much is operator dependent. So in adult hospitals, they tend not be as comfortable with abdominal ultrasound for appendicitis. But you can find things like, you have a young woman that comes into the emergency department in shock. You do your ultrasound. It's like, oh, there's free fluid down here in the pelvis. What do I think? I'm thinking this is a ruptured ectopic, and this is something that needs immediate surgical management. And that also changes our resuscitation, of course, as well, because they're bleeding, not third spacing. So the ultrasound can be helpful there as well. But I find the most helpful thing is just a good story, good history, like that OPQRST, the onset, provocation, quality, radiation, severity, and time of onset. But there are other few things, and we teach the OPQRST for everything, but things like, do you feel this urgency to defecate, this urgency of stool, which you can see that in inflammation of the colon, But you can also see that in vascular disasters. And usually it's a bad prognostic sign. If somebody with a AAA or a thoracic dissection says, I feel like I really got to poop, then that means you're dissecting into that inferior mesenteric artery and or blocking that off, and that's bad news.
So that's something you would see in mesenteric ischemia as well, just evacuation.
You could see that in mesenteric ischemia, which is why like the tradition is like, oh, well, mesenteric ischemia, the things stop working and you don't have diarrhea. Like, that's not true, because one of the first reactions when you get ischemia is to empty the gut. So that urgency helps. If you've got a lot of inflammation, you've got diverticulitis or really bad colitis, then that feeling of tenesmus, that constant need to defecate is something.
Can we sit with the pathophys for a second? So is that because of ischemia to the small intestine's colon, or is that just as if someone was hypotensive from anything, like if they had lost a lot of blood, or anaphylaxis, or is this something, or is it specific ischemia to that organ, or just hypoperfusion in general?
Well, it's ischemia to that organ, but remember, when you're in shock, your body starts shutting down perfusion to places that it doesn't need it right now. So if you're going into shock, then you're trying to preserve the heart, the brain, and you start shutting down the perfusion to other places. But then if you don't have enough to perfuse, then your gut's going to get ischemic. And this is something that we see in patients, septic patients, trauma patients that spend quite a while in shock. They end up with ischemic gut, and the gut can die off. And, unfortunately at that point, it's pretty much the skein of your life has been woven. So that can happen specifically with ischemia there, but also can be just sort of global. Now, it's still indicating ischemia to that area,
right?
But like global hypoperfusion can cause that as well.
While we're doing physical exam discussion, before we talk too much about ultrasound, I'm so glad that you spent a little time hovering around the physical exam. What is guarding?
So guarding it's kind of what it sounds like, where the patient, there's involuntary and there's voluntary guarding. So when you press on their abdomen, and you do so in a compassionate and slow, gentle, like pushing in, the abdominal muscles tighten up to protect it from doing that. Now, you may see some abdominal muscle rigidity overlying an area of ischemia, or not ischemia, but inflammation rather. So you have like that appendicitis, and now it's inflamed everything around it, and it causes tetany in those muscles, and you go to press on it, and it's hard as a board in that area. Or you've got pus just draining into the peritoneum, or abdominal contents draining into the peritoneum, so you get global peritonitis, and the whole belly is just hard and it's just rigid. So that's guarding.
It's involuntary.
Involuntary if you've got that spasm that's causing it, but then it's voluntary if you press on them and they react. Then that's voluntary guarding.
And why is it important to differentiate those two?
Voluntary guarding can be just somebody that, like, it's painful and they react in that way, especially if you are indelicate in your exam. But if the person has involuntary guarding, then that means there's probably a substantial amount of inflammation beneath wherever those muscles are, or if it's the whole thing, and that's somebody who's potentially in trouble. They've got peritonitis. So peritonitis, inflammation, usually due to infection of the whole peritoneum, and that needs immediate treatment. You need to, one, fix the problem, but two, antibiotics and fluid resuscitation and all of that, because they can get septic and die very quickly. A few other things. Anorexia. I don't mean like the chronic eating disorder from mental health issue. I mean, the person does not want to eat. Like, they just don't feel like they have an appetite. How's your appetite been? It's a simple question you can ask folks. And if they've got something going on here, anorexia, you tend to see that with like infectious processes in the gut, like appendicitis or diverticulitis and inflammation. You don't necessarily see that with a lot of other diseases. So that's an important piece. Like, their appetite's really fallen off the last day or so. Changes in bowel habits. So you may defecate once every few days. You may defecate 3 times a day. Whatever's normal for you. Is there a departure from that normal pattern that you have? Are there any genitourinary symptoms? Testicular pain? radiating pain into the vagina. So things like, in women, kidney stones or ovarian issues, ovarian torsion, that kind of thing can be problematic. Testicular torsion or epididymitis or chitis, these things can cause some belly pain as well. And then extra abdominal symptoms, so shortness of breath, chest pain, back pain, things like this may give you a clue as to where you need to go with that. Additionally, menstrual history. When was the last period? Was it normal for you? Was it normal flow, normal duration? How did it go? A lot of women have just normally irregular periods, and of course that ends up being a challenge. That's where your ultrasound comes in. It can be helpful. What's their surgical history? You mentioned looking, is there any scars here? You've had anything done? Because it gives you an increased risk of obstruction.
I read just a bit before this episode, and I read that 70% of bowel obstructions are from adhesions.
Yes. Mm-hmm.
Yeah, so mostly only get adhesions from previous surgery or an injury or something.
Previous surgery, previous injury, previous infection. Can do that.
Infection, yeah.
So, the other thing is alcohol use. So, of course, does it cause gastritis, inflammation of the stomach, cause pancreatitis, and potentially serious ones. But here's another one that's cropped up recently is THC, marijuana use. So when Colorado legalized marijuana, the ER visits for cyclical vomiting syndrome skyrocketed. We see this a lot. Like the weed that folks are smoking now is not the same weed as like Cheech and Chong, right? Much stronger, much higher THC content. While folks say, well, marijuana is helpful for nausea from cancer and chronic disease and so forth. Well, yeah, there are some antiemetic properties to it, but there are also proemetic properties to it as well. So cannabis hyperemesis syndrome, and we did a podcast on that. If the patient says, yeah, I get this belly pain, I get a lot, and sometimes I take a hot shower and it feels better, that can be a big clue that you need to ask them about drug history and ask if maybe THC is part of their life. The second challenge is getting them to believe you, because usually folks who use THC a lot can never believe that it would harm them and make them feel sick. Family history, certain things like diverticulitis, diverticular disease, colon polyps, they can run in families, cancer, of course. We talked about psychiatric disorders, but here's a big one I want people to take home. 25% of women of childbearing age who come to the emergency department with abdominal pain are victims of domestic violence. When you have that patient who's got belly pain, go down that road with them, especially if things aren't adding up with the history of the belly pain. Ask them about that. Hey, do you feel safe at home? You get a good history without their domestic partner there. This is a thing, and in fact, in our homosexual communities, domestic violence is more common. So ask that question. If you've got somebody, if it's recurrent or if it doesn't match up, and sometimes that's their way out of a bad situation. If they had a fight that was going bad, or a situation like they can see things are kind of going down the wrong way, they may complain of belly pain and say, okay, I got to go to the hospital, and that's their way out of a bad situation. So if you can clue into that, you might be able to interrupt a catastrophe and some terrible outcome and get them the resources they need. Yeah.
If I think about the gallbladder having kind of unique history we teach the 5 Fs. It's flatulent, female, 40s, fatty foods. There's a 5th one I don't remember.
Fertile.
Yeah. What does that mean? They've had a baby before?
No, it just means they were like somewhere in the childbearing age.
Okay.
But yeah, fatty foods, but fluffy also. So obesity is a risk factor for cholecystitis, and that's why it is becoming more common because we are seeing these rising obesity rates. It can also be a challenging diagnosis because it can be intermittent. Eat something and the stone drops into that neck of the gallbladder and blocks it up, and now it can't squeeze, can't go anywhere, and it can be very challenging to diagnose.
On a rotation recently, I saw an ER resident do ultrasound of the gallbladder, and they left pretty confident that the gallbladder was not the problem. Is that because ultrasound's pretty conclusive?
In certain disease processes, yes. Like the ultrasound can get you a quick, non-invasive, painless, fairly decent picture of a lot of structures. It's the diagnostic modality of choice for certain things. So you've got a gallbladder, then ultrasound is how we do that. If you've got issues with the ovaries, binding the blood flow, and so ovarian torsion, ultrasound really tells you a whole lot there. And it gives you an early clue if you have something like an abdominal aortic aneurysm. So you can see this huge caliber aorta and say, ooh, okay, that clues me in. Even though a CT scan ultimately gives you a much better picture, but you can do the bedside ultrasound on a patient that you're resuscitating and get an idea of what's going on with them there. So I love ultrasound for diagnosis, and ultrasound is one of those things like you can go further and further down the rabbit hole. Like,
right.
I do a lot of ultrasound in the field, but I am not at the level of, I even think some of the residents coming out now come out with such great ultrasound skills. They can find appendicitis, and they're really good with the gallbladder, and they said, I'm pretty good with the gallbladder. I'm really good with fast exams, and I'm pretty good with cardiac, but there's so much other things there. It's sort of like I can play tennis, but don't put me and Venus Williams on the same court because I'm not going to measure up at all. Ultrasound gives you so much, and you just carry it around. You have a butterfly, and so it plugs into my iPhone and throw it on there and gives me a good picture. But it can give you clues as the big deals that are happening right off the bat. So throw that ultrasound on there, and you see free fluid in the peritoneal area. You see a giant aorta. You see a baby in the uterus, something like that. It gives you a quick picture without harming the patient, and you just make that part of your exam, which is, I think, how emergency physicians now are doing. They're just roaming the halls with an ultrasound. Just
one more data point.
Yeah, it is. And it can give you some good pictures, and it can help you quickly rule out certain things as well, like that abdominal aortic aneurysm or that gallbladder that's an issue. However, there are limitations. So the abdominal aortic aneurysm, when that ruptures, tends not to rupture intraperitoneally. So you won't necessarily see fluid on the ultrasound when you ultrasound somebody that's got a AAA. So
where does it go?
It's behind. It's retroperitoneal.
Okay.
So it just doesn't, flow around the various organs in the belly. It can, but
so I need
to have to
pause you for a sec because Dr. Abraham texted.
Oh, God.
She wanted me to ask how intraperitoneal versus retroperitoneal presents differently. I guess, I don't know if she said organs within or bleeding within.
Intraperitoneal blood will show up on or fluid will show up on your ultrasound. Retroperitoneal, not necessarily. Retroperitoneal issues, you can get a lot more referral to the back, referral to the buttocks, referral to the perineal area, and that is that blood kind of tracks back there. And you're thinking about aorta when that sort of thing happens, or kidneys also. So if you rupture a kidney, that bleed is going to be retroperitoneal, or that fluid is going to be retroperitoneal. Won't necessarily pick that up on your fast exam. You may pick that up on a dedicated ultrasound of the kidneys.
Okay.
Same thing with the aortic aneurysm. You'll pick that up on just looking at the caliber of the aorta as it goes through the belly.
So why is the belly so terrible at telling us where the pain is? It's because there's not many nerves in there?
It's that visceral versus somatic sensation. So you have the gut, which sort of develops off of this one stalk and kind of twists and turns and everything. And the innervation goes with that. So unlike the rest of us where you develop these dermatomes. And
it's just like one long nerve along the thing?
Well, not really, but like all of the gut just evolves out of this one structure and then twists and so they're just not very intelligent as to where exactly the pain is. And so that's why somatic pain is much more specific. Visceral pain is really hard to pick up exactly where that issue is. And so that's where, like, when somebody comes in with abdominal pain and you don't get that diagnosed, then a bit of watchful waiting will help to tease out what the problem is.
So maybe that's a follow-up question is it important to know what organs affected?
Well, it is, because a lot of these are surgical emergencies. So they need to get urgent referral to surgery and to get that problem taken care of. Like the pus got to come out, tumor got to come out, whatever that is. So figuring that out early on is important. But here's the thing. 50% of people who come to the emergency department with abdominal pain leave without a definitive diagnosis. We're not that great at diagnosing that because it is so complex. You've got so many different systems that are involved, like that aren't even in the abdomen that's referred from somewhere else.
Right.
You know? So
like
it's
the DKA.
Like the DKA or the pneumonia or the myocarditis or pericarditis. These other things. So it's extremely challenging to diagnose abdominal pain, even when you have the full breadth of diagnostic capabilities at your disposal.
What are the risk factors for abdominal aortic aneurysm?
Abdominal aortic aneurysm. Here's another thing I want to that I want to get out there is a lot of folks don't understand the difference between a thoracic aortic dissection and an abdominal aortic aneurysm.
Okay.
So thoracic aortic dissection, this is where you have a little tear in the intima of the aorta, and blood starts dissecting between the layers of the aorta, which is by itself extremely painful, and it can travel the length of the aorta, and then it finds a way out. It tears through the outside, and then you're actively bleeding. And unfortunately, if that happens, if you're not on the operating room table when that happens, then the outcomes are extremely poor. The abdominal aortic aneurysm is a widening of the aorta. So you can have this sort of global widening of part of the aorta, or you can have what's called a saccular aneurysm, where you have just a bulging of one part of the wall. The saccular aneurysms are more worrisome because they are more likely to rupture as opposed to this sort of global widening. Now, people can walk around with the aortic aneurysms, and it's not that big a deal. Usually, if it's less than 5 centimeter caliber, then we don't do anything with it. We just manage their cholesterol and hypertension and so forth. So we manage risk factors. Once you go above 5 centimeters, then your chances of a rupture start going up, and those are things that we may have to manage interventionally, like either with surgery or now, which is more common than it used to be, is endovascularly. So thread a stent and a balloon up in there and reinforce that aorta that way. So much less morbidity with that, and it's an easier procedure for the patient to tolerate than opening them up and putting a graft in there. So the thoracic aortic dissection is typically as a result of hypertension, whereas the abdominal aortic aneurysm is usually cholesterol and vascular disease that
I didn't know that.
gets in there. So
I thought it was hypertension.
No, it's hypertension is bad for it, but it's that cholesterol that gets into there and starts kind of weakening that, and you get this dilation of the aorta.
That makes more sense. I mean, the thoracic aorta, you've got all this pressure, right, coming out initially, whereas the abdominal, it's just, it's still high pressure, but...
Yes, you don't want a hole in either one. You don't want the thoracic aorta or the abdominal aorta.
I'm so glad I asked that question, because
bad.
I've often thought it was just lifelong untreated hypertension, but you're telling me cholesterol or aging?
Cholesterol and vascular disease, aging, and now don't get me wrong, those risk factors tend to run together.
Yeah.
So certainly there's no reason you can't have both.
And then the mesenteric ischemia, I want to sit there for a bit because I'm not sure a lot of people have heard of that before today. Or I think that I know that AFib is a risk factor for that. Is that true?
Yes. So think of mesenteric ischemia like an MI or a stroke of the gut. You throw a clot into the vascular supply there and shut off that supply, and then the gut gets ischemic, it dilates out, and if it stays that way, then it's friable, it perforates, and truly awful stuff. And if it's a really proximal obstruction, like you clot off the takeoff point of the superior mesenteric artery, then that's going to be a terrible outcome if that goes untreated. So you can also have cholesterol deposits that cause a narrowing of that, and that's where you get that mesenteric angina. Somebody eats, and then they get this really bad abdominal pain a little while later. Like, all the imaging is normal. It's like, God, what's going on with this? And then so we'll do imaging with some contrast or some sort of vascular study of the belly to try to eke out that diagnosis. Again, pain out of proportion to exam is a big indicator for mesenteric ischemia. So it's like they look just miserable, and you press on them, and like, it's not that tender. It's a scary thing because it is so difficult to diagnose, and people may have recurrent intermittent mesenteric ischemia, and they just go on and they don't get answers, and it's really unsatisfying and really not fun.
MI is on my list. Upper quadrant pain.
Really, like, anywhere in the upper abdomen, you can have that, especially if you've got the inferior MI, so it's laying right along that diaphragm and can tick it off and or just refer down into that area. So anybody with abdominal pain, do a 12 lead EKG. Just
any abdominal pain, or you think?
Well, okay, like a 9-year-old with abdominal pain probably doesn't need a 12 lead EKG, but if they fit, just get a 12 lead EKG with belly pain. Now, if they have like truly like right lower quadrant abdominal pain in a 23-year-old, no, they don't need a 12 lead EKG. They do eventually because they're going to go to the operating room, but let us worry about that in the hospital.
I heard this kind of guideline once of anywhere belly button to nose pain.
Belly button and nose, do a 12 lead EKG. It's so easy for us to do now. We're so experienced. Like paramedics are doing them all day long. Like, you just get it. Like, it's easy. You know, spend the 50 cents on the leads and just do it.
Perforated ulcer. Are we talking gastric ulcer, duodenal ulcer, both, or more ulcers than that?
Yes.
What else can people ulcer?
I mean, you can ulcer anywhere really along the GI tract, but esophageal, gastric, duodenal. You know, even you can get ulcers in the colon, duodenal, whatever. It's in the gut. But I mean, you can get an ulcer anywhere, but it tends to be usually upper GI tract that occurs. So again, you ulcerate a lot of times right around vascular structures, and that's bad news, or you perforate through, and now you've got gastric contents spilling into an area that is normally sterile, and that's bad news.
We've talked about testicular torsion. Ovarian torsion doesn't get enough press, I don't think.
Because it's so difficult to diagnose sometimes, because it can be intermittent. Ultrasound, and you need to kind of catch it when it's twisted and when that flow is not going to that ovary. Just like a testicular torsion, you've got a limited period of time that ovary can go without a blood flow, and then you're losing the ovary, and that affects their fertility. That ovarian torsion also is incredibly painful. I think there are a lot of patients that, you know, young women who come in with this horrible pain from the ovarian torsion, and again, pain out of proportion to exam. And I think they get blown off a lot of the times. Like, I'm just being dramatic. And like, no, it's horribly painful. And so it's one of those things that we're looking for when we're doing the female with abdominal pain workup, which includes GU as well as the usual surgical stuff. That's one of the things that we're looking for. We're looking for that. We're looking for ectopic pregnancy, because the ovarian torsion can be immediately threatening to fertility. The ectopic pregnancy can be immediately life-threatening. And pelvic inflammatory disease, also bad infections, they can affect permanent fertility, because you can get scarring of the fallopian tubes. You can get septic and die. So the PID, which is typically caused by gonorrhea or chlamydia, so it's usually a sexually transmitted disease that can cause that. And the additional piece with that is that a lot of patients with PID are not really forthcoming because they're embarrassed. So they're embarrassed to say, I've had some vaginal discharge and this, or my partner just got diagnosed with sexually transmitted disease or something like that. They feel it's embarrassing, and so sometimes they're not forthcoming with some of that history. All those things can be terribly worrisome. It's an additional challenge as an emergency physician when you're diagnosing this stuff, because when you call OB with somebody particularly if you don't have a definitive diagnosis, and you've got a young woman who's in significant abdominal pain, you're like, I'm not sure what this is, but I think she needs to be admitted to do serial exams, and I'm worried. Well, OB says, it's not GYN, it's got to be surgical, call surgery. And you call surgery, like, well, she's a young woman, so it must be gynecological, and so called GYN, and you sort of end up in this match between the two of them.
The last thing on my list is black widow spider envenomation.
Yeah. Well, having just done a podcast with Spence Green about snakes, so black widow spiders, they can cause peritoneal signs. It can cause it so that Lactrodectus spiders can cause the venom can cause this abdominal rigidity, and can be extremely painful. And more than one person has shown up in the emergency department with abdominal pain that got tagged by a black widow spider. Those bites tend to be not terribly painful, and so they may not know that's what happened to them. I'm going to throw tetanus in there too. That tetanus causes abdominal pain. Fortunately, we vaccinate very well against tetanus. Tetanus is a horrible disease. You don't want to see somebody die of tetanus. It's terrible. Wow, you got a rigid abdomen. You got peritonitis, and it's like, no, they're totally unvaccinated, and they cut themselves near dirt, and there you go. But yeah, black widow spider is something that you can think of. This is why you don't mess with spiders. There's a couple of kids that ended up in the hospital with black widow spider envenomation because they wanted to be Spider-Man. So they found a black widow spider and let themselves get bitten by it. And it's like, oh, actually it sucks. Like, because you get like diaphoretic and the belly pain is it's kind of miserable when that happens. Like, oh, these poor kids. I also want to say, though, we got to be careful of certain populations, right? We talked about geriatrics, so much higher mortality rate because they just tend to have more worrisome stuff, and the cancers and the vascular issues and so forth. Pediatrics, because they can't give you a good history, also consider victims of abuse as well. Also, I want to throw something in there for the immunocompromised, folks with not just HIV, but who have AIDS, have untreated HIV, but any other immunocompromised patients, whether they have some genetic immunocompromise or they're on chemotherapy or something like that, they can have much more worrisome things that present with a more indolent course or less worrisome presentation because they don't mount this huge response to the peritonitis or what's going on with them, and also vulnerable to other infections that tend to be a lot less common in healthy immunocompetent adults. The cryptosporidium, and there's parasitic infections which can be problematic. Just watch out for those special populations. So treatment, stabilize the patient. So volume resuscitation if necessary. Now, it depends on what the problem is. So if you think that the patient has a bleeding issue, don't give them a bunch of salt water. Don't give them a bunch of crystalloid. In that case, they need blood. But if it is more of a third spacing issue, a sepsis issue, these infections, these intra-abdominal infections, then crystalloid, balanced crystalloid, preferably. So you're looking at lactated ringers, plasmolite, normal sol, isolite, something along those lines. Normal saline, really, like the more evidence we get, it's just not a great drug for people. But if they've got a bowel obstruction, there's a lot of fluid that they've lost through vomiting. There's a lot that's in the lumen of the gut. So you get bowel obstructions, the lumen of the gut swells, and so it third spaces, traps a lot of fluid in there. So appropriately volume resuscitate them, stabilize them, manage their nausea, manage their pain. For pain, I don't care what you do. Do fentanyl, do Dilaudid, do morphine, do ketamine, okay, but probably not your first go-to unless they're really unstable as far as pain control goes. And nausea management. So if you're using ondansetron, which seems to be the most popular thing now, also promethazine or prochlorperazine. Now, the haloperidol and droperidol are really good nausea drugs, and they're good for abdominal pain, particularly in those cyclical vomiting syndromes, the Cannabis hyperemesis syndrome, those kinds of things. So if you have that, then those may be good options. Now, don't snow somebody with haldol or droperidol, right? There's small doses for it, but they do seem to be really helpful in those really stubborn nausea and vomiting cases.
When you had appendicitis, what did you want? If you could have picked any med, what did you want?
So for me, the fentanyl worked better than the morphine did for sure, but I think that comes down to dosing. I think the problem with morphine is that we tend to underdose. So we get used to this 4 milligram IV morphine, which for a dude my size, 95, I'm approaching 100 kilos, 4 milligram dose is small, but we get used to that. And in the ER, I see this quite a bit. Like, we give 4 milligrams of morphine, this doesn't work, we give it again. Okay, we give 4 milligrams of morphine, and we're only barely approaching the appropriate weight-based dose. And they're like, well, it's not working. Can we switch to something else? Sure, give a milligram of Dilaudid or hydromorphone, and the weight-based dose for that is 0.015 milligrams per kilogram. So when you're giving somebody a milligram of hydromorphone, you're probably closer to the appropriate weight-based dose with that than you were with just a 4 milligram stock dose of morphine. Mm-hmm. But the fentanyl is very effective and works well. In the pre-hospital setting, it's great. The problem is that it doesn't last very long. And in the hospital setting, I want to give them something that's going to last quite a while, so they're not constantly the pain comes back and they're banging on the nurse call button and it's they have to go do more stuff. So I like something that's going to last longer for them once we're in the hospital setting. What I absolutely do not accept is when folks say, well, we don't want to give you any pain medicine because we don't want to mask the exam. That is utter horse. So do not do that. Treat their pain. does not affect the exam in a meaningful way. And there's literature on this that shows that, okay, well, does it affect the exam? Does it change what you're doing? No. So be compassionate. You treat their pain, do it early on, and don't worry about like, well, then I can't get a good exam. Like, it just utterly ticks me off, and emergency physicians will say that to EMS, like, well, you give morphine, now I can't examine the belly. Like, oh, shut up. That's ludicrous.
You mentioned giving blood for, GI bleeds or perforated things. Where does TXA fit into medical bleeding?
Excellent question. So there was a recent study on TXA and GI bleeds, showed really no benefit to it. TXA with traumatic bleeding, which there's a fair amount of literature that does support that. Not so much in like the GI bleed realm or the abdominal aneurysm or thoracic dissection realm. Is it going to be harmful? No, I don't think it's going to be harmful. But the other thing is you got to do it within a certain time period of the bleeding starting. And with GI bleeds, that can be really difficult to eke that out. So I hold off on the TXA now, especially in light of the more recent study that showed that it wasn't particularly helpful. The question is disposition, observation versus imaging. So if you have versus aggressive management, and there is a role for observational abdominal pain management. So a lot of times we'll do this whole workup on somebody. We don't find anything. Like, we don't find something that tells us, this is what's going on. This is exactly it. And so we'll send them home, or we'll sit them in the hospital and observe them and just do serial abdominal exams. For patients, and we see this now because we do a lot more telemedicine here in Austin for EMS. So we have somebody who's got like really completely normal vitals, like a very reassuring exam, a very reassuring history, and they're like, well, can we stay home? And okay, that's not unreasonable if you have a reasonable person that has good access to medical care, that has good access to the 911 system, not going to get lost to follow-up, that it's okay to give it a few hours to kind of see where things pan out. And we do this non-operative observation of abdominal pain all the time, like the suspected appendicitis. I'm not sure if they have appendicitis or not. Like, everything's so far. The exam's kind of concerning, but the CAT scan's okay. Labs aren't terrible, and like, all right, we'll watch them and we'll check them in 12 hours and see where their exam is. With the caveat that if anything gets worse, you spike a fever, the pain worsens, then call us back and we'll then take another look at you. So there certainly is a role for observation with abdominal pain or just general abdominal issues like nausea, vomiting, diarrhea in the right population, the right low-risk population with good vitals, good exam, reliable, all that stuff, then that might be a way to go. This is not just I don't feel like taking you to the hospital, just go see your doctor or whatever. No, you got to have a good feeling of what's going on and a good plan moving forward, one that the patient fully understands.
Yeah. Thank you, Dr. Pickett.
Thank you, Professor Locke.
It's been a pleasure.
It's great to see you again.
It's good to see you too.
Sorry, like all of these things, like pandemic and everything else, just
deployment.
It has kept us away and kept us from doing this.
Let's do it again soon.
Oh, I'd love to.
All right.
All right. We'll see you. White Tiger.
Bye.
Out.
This episode of Medic Mindset is supported by iSimulate. From the very beginnings of this podcast, I've been committed to keeping Medic Mindset always and forever free. Their support allows me to do that. Thank you, iSimulate. Every episode of the Thinking series showcases an artist within our ranks. The artist who captured abdominal pain in a custom piece for this episode is Mo Pitzer. They create these great digital collages as a way of processing their calls. Go check out this art and art from other episodes under the Artist tab at medicmindset.com. Oh, they're not right.
No, they're not for her, but
I don't know what this means.
Thank you for reminding me that the entire ASAP Tactical section now thinks that I like My Little Pony dolls, thanks to Dave Calloway, MD. Professor Dave Calloway.
Wait,
yeah, I feel like
this is my show.
Oh, yeah, it is. Well, now, you got the headset. I don't have a headset. I feel like I need that.
I did offer you a headset.
You absolutely did, and it's my fault, but you're wearing it. Now I feel left out. I feel weird.
There you go.
Well,
I'm going to do these.
You have two headsets? Well, no, we both need to have like this kind of headset if
why?
we do that. So we look like John Madden and Pat Summerall. That's why.
You and your theatrics.